And we're recording. Hey, this is by the way, this is One Take with Jess. So this is how it goes. Like I'll start and then it'll be however it comes out of my mouth.
I like
Um,
it.
hey folks, my name is Jessica Mashkovich and I am the host of One Take with Jess. Today my guest is Dr. Pascale Tufau. Hey.
Hi.
Pascale is a longtime, lifelong friend of mine. We go back to itty bitty land. And
Mhm.
oh, by the way, I started singing our Fallsburg High School song in my head the other day. Do you remember what it was? I don't know where it crept out of. Did I
No.
make it up or is it like Fallsburg Central,
Oh,
greatest
it
in
is
the
in
land?
the land. Now that you say it, yes, the memory is kicking in.
Yeah, colors flying,
Colors flying,
friends
strength
undying,
undying,
courage
courage
we
we
band
will band together.
I don't know what, like, you know how much that was taking up like space. This is why I can't find the butter in the refrigerator sometimes. I'm like, because the Fallsburg Central song is in there.
Well, I got snatched into it. Like I really just was like, oh yeah, I do remember.
Now you'll be singing it for the rest of the day.
Thank you.
You're welcome. But I'm going to give you guys a little bit of history behind Dr. Pascale Tufau because I was reading this and I was like, I know her my whole life, and I'm so impressed reading this. You did
Oh, thank
done
you.
good.
Thank you.
Okay, so Dr. Pascale Tufau attended Carnegie Mellon University, where she received her Bachelor's of Science in Microbiology. Then you attended, I'll speak to you as you, then you attended NYU to get your doctor degree or medical degree, your
Yep,
doctor
School of
degree.
Medicine.
Yes. And then you did your residency at Johns Hopkins Hospital.
Hmm.
And then you're currently, or you, I don't know if you then went to the Greater Baltimore Medical Center where you
Hmm.
were at again, probably like 10 years after that,
Right. I
right?
worked there briefly, and now currently I work for Capital Women's Care in Fredrick, Division 33.
And you are an OBGYN. So your
Correct.
specialty is obstetrics and
Obstetrics and
gynecology.
gynecology. Hmm.
And you did do a little time with Haiti Heritage and Friends of Haiti. Is that an organization that you were
Correct.
a physician with for a little bit of time?
Yeah, I did. I had the opportunity to go on a mission trip, and it was really eye-opening. Um, we went to this church, and it just, provided healthcare for about a week. This organization would go, I think it was every 6 months. And so, they had
Yeah.
their routine patients, and it was impressive to see how long and how far people would travel for this healthcare visit. But it was wonderful. And then I ended up going right back again because I think that was 2009 or 10, and then the earthquake happened. So then, because I had so many friends on board, I went back again. I think 4 days after the earthquake,
Wow.
and
And then,
worked in Himani,
uh-huh.
which is just on the border on the Dominican Republic side. And again, was grateful to have the opportunity to help patients there as well.
Were you doing just general internal medicine or were you doing obstetrics and gynecology there?
Everything.
Everything.
I remember I literally was driven to, I think when I arrived, like I got there and it was kind of like do what you have to do in order to help, right? So I came fully prepared, tent, everything. I slept actually on top of the hospital the evening that I got there. The morning I guess they found some accommodations for us. And then when I arrived, they were like, "Oh my God!" They some of my friends had recognized me from doing the mission prior. So I like got out of the car right into a C-section. So I was like, I'm here. However I can help, I'm happy to help.
Wow. Wow. I mean, that's fantastic. And that really fills your heart, because you were of
Absolutely.
service, certainly
Absolutely.
needed, essential at that point for sure. And your family is from Haiti. So did you?
Correct. So I would link up with, when I went for the first mission trip, I went with the group and then afterwards, reconnected with my family who came to, I just spent like the last 2 days, like I did my week and then went and visited with my family for a couple of days before coming back to the States.
Yeah. Well,
So,
that's good. Was
mhm.
it, what kind of conditions were you working in?
For the mission trip, the first mission trip, just we were
And
in a,
then I guess even after the earthquake,
yeah,
did things shift? Were you in a
um,
makeshift type of hospital, or was it still the main hospital?
so for the first mission trip, we operated out of a church. And so during the day, we would push our sleeping bags and tents to the edge, and then we would receive patients in the middle of the church. And it was kind of nice because you would see an entire family at once rather than just seeing individuals. These individuals came in groups and they typically were related to each other. So you would just kind of see the whole family at once,
Hmm.
and treat the whole family at once. And, I do speak Creole, I speak French, I speak English. So it was kind of just really nice to be of service, in my parents' home country. I'm first
Yeah.
generation in the United States. And then when going back, same thing. I served medically. At one point, a surgeon needed a translator. I would whatever was needed to be done. My official job there was we ran, after the surgeries were performed because it was mainly orthopedic based, right? Because of the nature of, the natural disaster. Myself and a general surgeon, he's from New Jersey. Um, we ran the PACU, and the PACU, post anesthesia care unit, happened to be in the outside chapel, and then they had put up a tent, as well. So we received all the post-operative patients that could stay, and then we helped triage who needed to go to. At that time, it was the U.S. Comfort. The U.S. military was flying back and forth, helicopters, and
Hmm.
sort of triage the patients, see who could stay with us, who needed to go on to the Comfort, or whatever else they needed. So
Yeah.
it was a lot of work, but it was extremely, extremely rewarding. I feel lucky to have had that experience.
That's awesome. I think the U.S. Comfort or USS Comfort, whatever it's called,
Right.
was stationed out right outside of the city for
Mm-hmm.
the overflow during COVID. They were
Mm-hmm.
supposed to be accommodating, what the hospitals weren't able to, but I don't.
Yeah.
But that's good. That's nice that that ship shows up when needed,
It
where needed.
really, it's a blessing.
When you were in Haiti, did you find that the medical supplies and the uh, instruments and tools and machines that you were using, or technology, I should say, what was the level of technology that they had compared to the United States? Did it make you feel thankful of what we have here in terms of technology, or did you see opportunities where Haiti can benefit from whatever we have?
Well, for the first mission trip, I was truly, I was on top of a mountain and it wasn't, an operative. It was more like a, family medicine type setting,
Hmm.
right? So there was no opportunity to operate. That wasn't what we were there for, just basic medical care. But when I went back for the earthquake, I was in a completely different location. And I can honestly tell you, that was actually a Haitian physician who opened this surgery center right on the Dominican border side called Himani. And it was state of the art. I mean,
Oh, that's great.
oh my God, it was, it was beautiful. Um,
That's
I
wonderful.
can't think of something we didn't have, except, because his center was actually not slated to open yet, but he opened it with the help, I believe, of the U.S. government and the, Dominican Republic and the Haitian government opened it early in order to help the, earthquake, victims. We were just waiting like 1 or 2 days for imaging, but besides that, honestly,
Nice.
it was
They had it all
really
going on.
everything. Yeah, they had everything.
That's perfect.
Mm-hmm.
So I just want to continue of the beautiful overview that was written of you, because it was written so well. I was writing my own and I was like, why? Because this is so nice.
Thank you. Wow, where did you get this?
I'll send you the link. You could put it on the
Thank you.
refrigerator. This is something where you show the kids, you're like, look what mom did.
Uh, I'm a cab driver. Okay. You know what I mean?
You're a
I'm a
glorified
Uber
Uber.
driver for them. Yeah.
Yeah. So let's see. It says here that you graduated with the title of resident most likely to help a colleague. So that means you're just as kind as you always have been before. The same Pascale I've known and loved. And you earned board certified American Board of Obstetrics and Gynecology. And you love the diversity of offered by the field of obstetrics and gynecology, and you're particularly interested in minimally invasive laparoscopy. The words are just not coming out.
You're fine.
Laparoscopy. There we go.
Mm-hmm.
A couple of extra O's and A's in the right places makes a difference. Laparoscopy procedures, high risk obstetrics, adolescent gynecology, and the transition into menopause. So it sounds like you are hitting all of the even age-related milestones of your field, which is appropriate. And you're thrilled to be practicing in your cousin's hometown of
Yeah.
Fredrick, Maryland. So
Yep.
you haven't strayed too far from family. It's nice to know that you're still near your family.
And funny story, we all went to medical school together.
Wow,
Yeah,
that's
we call them
amazing.
the Twin Towers because they're twins.
Yeah.
And so the three of us went to medical school together, I tell you.
What form of medicine did they go into? What's their specialty?
So one went into family practice. He's actually in Indiana, and the other went into emergency medicine, and he is in Beaumont, Texas.
Oh, very nice. Okay, well, I'm
Hmm.
happy for your success. Now let's get into the nitty-gritty of babies and things, and you're basically releasing the next version of humans to the earth. Kind of like in software and technology, you're releasing
Yeah.
the next iteration of the software or whatever. You're
Yeah,
putting it out there to the market, the next version of human beings. So that's got to be exciting.
it is. It's a blessing every day. I'm very lucky to do this. I love what I do. I enjoy taking care of the patients. Um, it's really wonderful to see these families, growing. You have the people who are coming back, the people who it's their first time. It's beautiful. It really is.
Is your wall kind of filled around Christmas with all the cards of, we have to send it
Yeah,
to Dr. Tufau. She brought you into this world.
yep. There's a lot of pictures, a lot of joy.
That's good. So,
Obstetrics can be extremely, extremely happy, and it is very, very rewarding.
but it is challenging, and I'm sure you have those moments
Hmm.
where things are supposed to be coming out and they're not coming
Right,
out, and you're like,
right,
hey, we're just going to
right,
pivot
right.
and everything's fine, and you're just making sure that your group is doing what they're doing to release that
Help
human
these ladies, exactly.
in as best health as possible. Um,
Yep.
but when COVID came along last year, I actually had a cousin that was pregnant and she was due to deliver
Oh,
during the COVID season. Um, it turns out she's in New York, and at that time, like, they did allow her husband in the delivery room.
good.
But that was months after they had declared nobody's allowed to to be in delivery rooms. You kind of have to deliver by yourself. No husbands, no partners, no visitors, no nothing.
Hmm.
So she was thankful that he got in under the wire.
Right.
Um,
So our
yeah.
institution just decided not to do that. We, used every precaution, but our institution decided to always, have that support person there. I, um, I understand why certain institutions had to maybe make a different decision. It's just very hard. That woman does need, all the support she can get.
Right.
It's a long, arduous process. And, we just try to be there for our patients through this scary time. COVID was very, very scary. Had patients who just were trying to decide between home births and coming to the hospital. And, we were like, wow, it's terrifying for someone if they don't see this every day. They see what's happening on the news and they're just so
Yep.
petrified to even leave their house.
Did you have to do that? Did you consider thinking about taking your show on the road and maybe going to people's houses in order to, to do a home birth, or having like a mobile medical vehicle that was there just in case?
No, mm-mm. We just talk to them a lot, and most people, once we explain to them all the precautions that the hospital had put in place, and understand that we really had sort of done everything we can to diminish any risk to the patient or to the baby, that they became more comfortable just through constant conversation, reassurance. We had a lot, PPE on board, testing on board, and through the evolution, at first we didn't have testing, then we did have testing, or if we did have testing, it took a week, and then finally it got to the point where, hey, we can tell you your result in 20 minutes. So just working through the kinks as a team, we're able to provide comfort and reassurance to our patient population.
Yeah,
And
that's
we
great.
had, positive outcomes.
Perfect. And then for
Yeah.
people that did want to do home births, do you have what's it called again?
Midwives.
Midwives. Do you
So,
have a set of midwives that you would refer to, reputable? Because I could imagine that's probably a whole.
so our practice is physicians.
Mhm.
We
But
do all
just
the
in case someone
deliveries.
was insistent.
So our practice does not have, my particular practice does not have midwives. So
Okay.
we would just, I don't really know that
Yeah.
they could look up midwives. Oh yeah,
Uh,
we are.
Most often it's referred by a friend who had, a successful relationship. Um, but yeah, I mean, that's always iffy for me. That just makes me feel nervous that,
Right. There
you
are
want to
other
be,
practices in the area that have midwives. So, I wouldn't
yeah,
keep it a secret where they were. And if
sure,
that's the path
sure.
that you want to take, that's great.
Yeah. As long as there's, room for the what ifs, and, you want to make
Right.
sure that everyone's safe, especially with that. Remember the next release of Humans, it's got to come
Yep.
out good. So let's talk in utero for right now. And am I using the right word? But
Yeah.
before a baby comes out, there has been some talk that mother has to stay calm. Stress hormones from the mother can get
Hmm.
imprinted actually on the child. These are things that people say, and basically, I want to know from you if there's any real credibility to any of that, because you have women that are exercising rigorously at times. I was doing the Peloton, and it was a floor exercise, and the woman was pregnant, and I was like, oh my, I didn't realize it until she turned a specific way.
Was
I'm
it
like,
Robin?
it might
Was
have
it
been.
Robin Arzon?
Did she just give birth?
Yeah, I know.
Then
She's
yes, it
amazing.
was.
Love her.
Then
Okay,
it
anyway.
was. And I thought she was a little bit thick around the middle. And I'm like, hey, girl, me too. I was relating to her. And then I'm like, oh, she's pregnant. I'm just thick.
I love Robert Arzon, and here's why. Because I think she's such a fabulous example of what our bodies can do and what our bodies were meant to do. She's a type 1 diabetic who is at the
Is she
top of her
really?
games in terms of exercising. And that's the model I want for my patients. When I was pregnant with my children, I worked out with a trainer both pregnancies until she was a little annoyed that I couldn't do all the moves. But, I just try to tell people we aren't meant to just sit and kind of wait till the end. I more so encourage my patients, hey, you know what? We're actually like kind of training for a major event. And the major event is labor and
Mm-hmm.
delivery. And if you train a little bit every single day, the main event, you'll be more comfortable and more confident and more able when the main event comes. And when you put it to them that way, then they understand like it's okay. Now, we're not talking about ladies who we've explicitly told not to do certain exercises because of certain medical conditions. I'm talking
Hmm.
about the normal pregnancy. Yeah, you should exercise, you know, you should be active.
Yeah, I wish someone had told me all this because mine was like, that's fine. You can eat, you can whatever, just as long as, for whatever weight you gain, it'll take you just as long to take it off. So, but you'll take it off, it'll be fine. But I used to be exercising. And then when I was pregnant, I was like, okay, cool. Now I have to chill and let it grow and
Hmm.
then, eat my Cinnabon. And that was delicious. But
I'm sure.
it wasn't in my best interest because after delivery, I did have a back problem. I wasn't
Mm.
as, physically ready to
Hmm.
handle all of the stuff, post pregnancy for recovery, but that's fine. Then
Hmm.
you try and get yourself back into shape. But that's great advice. And that has always concerned me watching pregnant women exercise because I don't know if they're stressing themselves out. And is that the same stress hormone as stress? Like you can, but then
Hmm.
again, it's supposed to be a stress relief exercise.
Exactly.
Okay.
So for a lot of ladies, exercise is their way of decreasing their stress level, right? It releases endorphins, you feel better about yourself, you feel confident. The human body is amazing and it can do quite a bit. Um, I've been passed by, I'm sure, 8-month-old moms pushing, that double stroller with 2 kids in it uphill, and this lady who is like 8 months pregnant is passing me. So the human body is amazing. It is just something that, if people understand and you put your mind to it and long story short, you're supposed to be mobile. You're supposed to constantly keep
Hmm.
moving. We weren't meant to be sedentary beings. And you and your children and your child will do better. You're decreasing your risk of diabetes, hypertension, obesity, and all that comes with that, and the
Hmm.
complications that can come from that in pregnancy.
Yeah, I agree. Is there anything that we pass on or imprint onto or into our children while they're still in there? Um,
So I'm not
Good
so
and
sure
bad.
about that. I'm not really sure that. I mean, I can understand a traumatic event, maybe, but just like routine stress, I don't know about that. I don't think it really passes to the child if,
Do you
you
mean a
can just,
traumatic event that physically may harm the baby or a traumatic event that the mother goes through
maybe if she
mentally
goes through a traumatic
stress?
event, because, it's probably not going to be completely resolved in, meaning in terms of mental health by the time of the delivery, and she may be affected with postpartum depression or postpartum anxiety. So more on those terms, but I can't say that, um, you know, stress imprints on the baby. I'd have to do a literature search. I haven't seen papers on that.
Hmm. Okay. I'm kind of jump topics because that's how my brain works. I may need
Hmm.
medication for that, but that's fine.
All good.
um, One side is saying let's talk about peanut allergies. The other side is saying let's talk about marijuana.
Okay.
Um,
Peanut allergies in children or in the mom?
Peanut allergies in children.
So I'll defer to my colleagues in pediatrics.
Okay. Is it hereditary at all? Is there any
Uh,
hereditary link? No, no idea.
I'll defer to my peds colleagues, yeah.
Okay. Is there anything in particular that pregnant moms should or should not eat that they don't know about that might harm the baby? Like, for example, leafy greens are supposed to be good, but, may have an adverse effect somehow, some way.
So certain fishes, we don't want you to have more than one serving per week because of
Mercury.
increased levels of mercury, and those can cross into the placenta, and they can accumulate, okay, and then they can accumulate in the brain, and they can affect the baby later on in life. We want all your foods to be cooked. We would love for you to avoid nitrates, um, little things like that. So, but for the most part, unless the mother, just to swing back again, my brain does the same thing. Unless the mother has a peanut allergy, I have not told any of my patients to avoid nuts.
Okay. Got it. How important are prenatal vitamins, and are they over the counter?
Over-the-counter vitamins are good. I tell people to get those every day. In the first trimester, we're really trying to make sure that you have folic acid, a bare minimum of 400 micrograms per day, ideally 800 micrograms per day of folic acid, and that's for brain and neural tube development. In the third trimester, we want to make sure that you have adequate iron because your baby is building its blood count, its blood stores, and it needs iron in order to build its own blood volume, let's say. It's also important to have adequate vitamin D. Studies have shown that it can decrease miscarriage levels. So there are a lot of vitamins in a prenatal. I don't think any of them will hurt you. Most of them will help you. And an over-the-counter prenatal is just as good as the prescribed. So I just usually tell the patient whichever one is most cost effective.
Mm-hmm. Are they essential? What if you have a pregnancy all throughout where you didn't change anything about your diet? You didn't incorporate any sort of supplements. What could the risks be and how detrimental? I mean, for me, I'm thinking that you're pregnant, prenatal vitamins are top priority, number one. And then you could do whatever
I
you want.
agree. So the main things in the first trimester are folic acid, vitamin D, right? Folic acid is helping to make decrease your risk of neural tube defects. That's why we really would love for everyone to have had 3 months prior to conception being on a prenatal vitamin or bare minimum taking folic acid and vitamin D.
Prior to
And then
conception.
ideally 3 months prior. In a
Okay.
perfect world,
Yeah.
everybody would take their and for most ladies, that's going to be like your routine multivitamin. The good news is that we're here in the United States, most foods are fortified, right? So it's if you eat cereal or eat bread, it's kind of hard to drop below that 400, but a neural tube defect that is preventable is, just from taking a little vitamin, I say
Mm-hmm.
take the vitamin, right? Then in your first trimester, those are the two things that are most important in the prenatal vitamin. And again, in the third trimester, we're most concerned with the iron levels.
Mm-hmm.
So
Do
did
you
that,
did you see that, like, for example, in Haiti, where were
yeah,
people educated to the sense of health education, and like
yeah,
how would you help pockets of people that even in the United States that aren't alerted to the fact that this is like super, super, super important?
super important. So, when you do mission work, if I'm not sure if Haiti fortifies its foods, but we would hand out 90 or 100, 20 folic acid pills to get the woman through the first trimester, and then we would give her 90 iron pills to get through the third trimester. So we always handed, all the pregnant ladies got 2 bags.
Mm-hmm.
And we were like, take these, and then may or may not take it in the second trimester. And then in the third trimester, we're trying to help them with their iron stores. So, yes, we did a lot of education, handed out a lot of vitamins. Um, I will say those ladies are they're very active. Like you're seeing ladies who have just, walked 15 miles to see this clinic and then are going back home. But yeah, we did a lot of education in terms of diet, not so much exercise because
They're good.
their life is exercise.
Yeah.
Yeah. So, and oh, actually, when I went for the first visit, I was fortunate enough to do a delivery. This lady, it was her sixth child. And so here in the United States, we have midwives. They have I guess, a mid husband. So it's mostly men who are doing
Okay.
the midwifery.
Wifery.
Yeah, I was
Wifery.
like, I don't really know. Oh, but this was
Midwifery.
awesome. So it's the middle of the night. We're up at the church. The church sits like on a mountain. So myself and I was with another OBGYN and a couple other people. We walk down. We go to her residence. She's laboring on the floor. Oh, the mid husband comes to get us because this is her sixth baby, and he's like, I think this is taking longer than it should. No problem. We go down there. I check her. I'm like, oh, okay, yeah, this is taking longer. So poor thing, we didn't have like a car or anything. We're walking these miles to go to her residence, and then we're walking back up the mountain. because we didn't have a car. This
Mm-hmm.
poor thing has to walk up the mountain in labor.
Oh my
And she never
gosh.
complained. She
Yeah.
walked
Oh,
up, and then we didn't have hospital beds. We're just in a church. The thing we had was an army cot. We put her on the army cot. We didn't have an IV pole. We had to use a violin or whatever, the big one.
the cello thing or
Yeah, the cello or the bass as the IV pole. We get her all hooked up, and she delivers, and she is the skinniest, smallest little lady. She has the shoulder gets stuck. Thank God. Me and the other obstetrician,
no.
we were just like, really? So anyway, we have a successful delivery. The baby's great and everything. But
Wait,
I was,
wait, what'd you do? Did you
the
reduce? Did you
different
break the
maneuvers that
vaginal
we have
wall?
to
Okay.
do. No, no, no. We just did all the, oh, it was one of the labor and delivery nurses was with us. So it was myself, another obstetrician, and a labor and delivery nurse. So we were just like, okay, we don't have monitors. We're just like, okay, we're
Yeah,
gonna do it, just like births happen all the time, right? We're not necessarily in a hospital.
right.
So, it's so weird because when I was leaving Hopkins, I'll never forget, the chairman sat us down and he was like, what if you are doing mission work and there is no bed? Because we're so all used to that bed that drops out in the middle. He's like, what are you going to do? And I swear I could hear this man in my brain as I like doing this delivery because I'm like, you turn her on her side, so we do the whole delivery. It works. We have a successful delivery. And then,
Wow.
this lady received, I kid you not, just 2 Motrin, the ones that we buy at the store. 2 Motrin. She had had all her children with no pain medicine. We gave her 2 Motrin, and she felt like she was at the Four Seasons Spa. She was so happy.
Oh
She
my
was like,
God,
oh
that's
my
like her
God.
morphine. Two
I
Motrin
mean,
equals morphine.
2 Motrin. I was like, wow. She ended up naming the child after me. So
Oh, oh my God, that is such
I
an
know.
honor.
It was such a just an honor and a fabulous experience. She just kept coming back and going on and on about the 2 pills.
You know what? That's what makes this whole thing worthwhile. Like you going on a mission and doing this type of delivery in way unfavorable situations, but you made it work.
It
That's
made it work. And you realize,
I just got the
people
goosebumps.
are just people. And anyway, it was my honor to be there.
Yeah.
I was
Wow.
truly, truly humbled and just it was fabulous. I really, really, I enjoy mission work. I wish I could get back to it. And as soon as I can, I will.
Oh, that's good. Do you suggest that for the youth of today, and whether it's medical or just helpful or anything? Because they always need volunteers to go places and do things, so
So I have, ultimately, the answer is yes. But here's what because I have family who lives in Haiti, and I believe in seeing something through, right? So if you're going to go, like maybe, and I'm kettle calling or whatever, the pot calling the kettle black, like go and make a concerted, continuous contribution. There's called like um, volunteer tourism.
hmm.
Okay, so
Which it sounds like you don't like when you come and
I don't
stay for four
love
weeks or three
because,
weeks and then you
right,
move
like,
on.
right. So I'm more a proponent of let's teach the people here
Hmm.
how to help themselves, and then they're moving ahead also.
Okay, got it. So
Not
you're
that
teach a man to
we
fish
come,
with
we do
empowerment.
everything, and then we pull out and they're still left in the same predicament.
Yeah, that's
I'm not
true.
a fan of that.
That is true. But as far as growth for like our children, your children, my children, it might.
Again, I believe in a sustained, continuous
Hmm.
contribution, not a week and then you might never go there again. And
Yeah,
again, I'm putting myself out there too.
sure. No, I think
So there
that's
are some groups that do
certainly a
that, and
good
then there are
view.
some groups that come in and out, and I have a lot of thoughts on that.
Sounds like you might be setting up a nonprofit soon.
We'll see.
um, let's change or shift gears to the marijuana question. And I only ask this because this is on the heels of New Jersey approving it for recreational use. Colorado's approved it for a while. I think Illinois or, California, of course, for a while. And everyone's all unclear on the effects it has on the brain, on the body. There's certainly medicinal uses for marijuana that are favorable. Our friend of ours had cancer, and it helped her get a little bit of her appetite and get through. She's no longer with us. May she rest in peace. But there are certainly some aspects of it for sure, but I don't know the usage that people, or the comfort that people might be having, or the casualness of using it. So is there a particular warning to pregnant women or breastfeeding women that may be using that particular method, whether it's smoking or edibles to fall asleep or to whatever? They may be even using it in a self-prescribed medicinal way, but maybe this might be a good opportunity to talk about some things that might not be so great, or might be great.
Right. So the official guidelines are that we do not recommend any form of marijuana in pregnancy. It has been proven to have long-term detrimental effects on the fetal brain and the children thereafter. So black and white, we do not recommend any form of marijuana in pregnancy or in breastfeeding.
Okay, good. Thank you.
Sure.
I might just soundbite that just for, informational purposes. Let's talk about the people and the age that you're seeing people getting pregnant on average. Are women older than they used to be? What's the industry-wide thing going on now with women?
For our particular practice, I think, yes, they're a little bit older. But I think, that's just normal because, maybe somebody was going to school, and by the time they finished school and felt established enough to start a family, I would say the 30s is early, the entire range of the 30s. That's where the bulk of our practice is. We definitely have a good contingent in their 40s, and they're doing great too.
What age is it considered like a high risk type pregnancy?
So I know the official guidelines, we have to say 35 and over, but the reality is there are 35-year-olds, or excuse me, 40-year-olds who can run circles around some 22-year-olds, right? I mean, these ladies are fit, and so we thoroughly encourage them. I mean, if that's what you want, if you want to complete your family, talk to your healthcare provider and look at your particular risk profile. I would never tell somebody just based on their age.
What are some attributes that are considerations in a risk profile that their healthcare provider might point out? What do you even have to ask?
If you have a normal BMI, that's fabulous. If you, what are your medical problems? Do you have hypertension? Do you have diabetes? Those are the main ones. But
So
if we can start to get those, if we can start to control those things, diabetes, especially if we can get your diabetes under control before you conceive, if we can get your hypertension well controlled before you conceive, and if we could get your BMI as close to normal as we can. Those three things can really make a difference. It can decrease your risk profile greatly once you then are pregnant.
Okay, so that's good that you have a lot in your control to mitigate any risks that you might see, or any pre-existing conditions that might be exacerbated by a pregnancy.
Right, because it'll only get worse in pregnancy. So if we can get it under control beforehand, it really makes a huge difference. I cannot overstate how much of a difference it would make.
How about the consideration of the number of eggs a woman has in her body, which apparently are there
Yeah.
right when you're born? You already
Yep.
have like all the eggs you're ever going to have. And how
Mhm.
does the shelf life of those eggs
Right.
factor into the
So
equation?
after 35, it does start to fall off. We have two different things, right? The fecundity rate, which is the rate of getting pregnant, and then we have um, sort of like what is happening with your eggs. Yes, the number of eggs every year it's going down. And more so the quality of the eggs, right, is going down. So that's really what we're talking about in terms of, screening for, chromosomal abnormalities and the such. But typically the lady is using her own eggs, depending on what state you're in. Here in Maryland, I think it's pretty much if the quality of the eggs is good, I want to say 45 is the cutoff, and then the REI, or excuse me, the infertility specialist will probably, somewhere between 40 and above ask about donor egg. After 45, definitely donor egg, just because the risk is high. Does that
Because of the
answer?
quality. Yeah, yeah,
The
yeah. Yes,
quality of the
yes. The
eggs
shelf life.
and
It's not
the
like Twinkies.
right.
It doesn't last
But,
forever in the same format.
technology is beautiful. If you choose to use your own eggs, you can conceive spontaneously, or if you're going through an infertility specialist, you can do pre-implantation genetics. So there's a lot of options,
Do you work
and you just
closely
kind of
with
have
a
to fit with,
fertility specialist in your
yes.
office
hmm
or
Not in our office. We're
just
general OBGYN, but with different practices in the area, that's their specialty.
okay. Um, do you have any thoughts on genetic modification in terms of, I guess that would be more of the fertility question and the ethical side of it, or you know, making any
Mm,
adjustments prior to the chromosomes, to the eggs, to the before it's implanted and
yeah, that's not, I can't say that that's not, to my knowledge, I don't think our colleagues in infertility, at the center right next to us are doing that. Um,
Mhm,
what I'm talking about more is screening all of your embryos prior to implantation. It's called pre-implantation genetics,
mhm.
just so that, you can select the embryos that you want.
Okay. And then they still have to mesh nicely with a sperm as well. Can you pre-select sperm? That's a lot of
So
screening.
So we're talking about after the egg and the sperm have been put
Oh,
together
okay.
and then they've been made into embryos, and
Okay,
then
I thought it was
you
just
can
your egg
yeah,
supply.
you can
Okay.
take like a sample from the outer barrier and you can test the chromosomes on that, and then you can make your embryo selection, sort of like, okay, well, I'm going to select these.
Wow. Okay,
hmm
that's interesting. It's all locked in there, like right away. It's all locked in, and this is what you're going to get in
hmm
door number one and door
Yeah,
number
that's
two.
door number two. So
That's
yeah.
amazing. Wow. Um, what are your thoughts? Okay, two questions again. Sensitive topics. Stop me if you choose not to answer or whatever. But when how does your office feel? Maybe that's not a good word. From a clinical perspective, if someone came in and said, I want to terminate the pregnancy, is that a medical procedure handled by your office? Are you allowed to opt out and say, we don't do that here? Or is that a medical procedure handled by someone else or a hospital?
So our practice has decided as a group that we do not perform terminations, but we will help you find healthcare providers that do perform terminations and help you, guide you to the appropriate services.
Okay.
But as a practice, we've decided that, we're just not comfortable performing them.
But you do refer them
I
to a reliable, compassionate
We will give you a
organization.
list of names and locations, and I love the practice of medicine. There are like these questions that you're asking, sort of pre-implantation genetics, termination. I look at, my job is to help guide you, and not judge you.
Mhm. Good. So don't judge me by the questions either. Um, the other one was oh gosh, it was that, and then it was, I forgot what the other question was that I was asking about. Oh yes, um, hormonal
Replacement?
treatment, hormonal replacement when it comes to menopause, or maybe any time during a woman's life. I know the
Yeah.
hormones come into the picture when you're trying not to get pregnant,
Yeah.
control pills, and
Can use them lots of ways.
yeah. Um, is there a problem with too much, too little? I know it serves the purpose with birth control, and people, take the chance. It could increase
Right.
breast cancer. It could
Right.
increase this. It could that. But
So
talk to-
I think you always have to look at the patient and her particular medical history, right? We always start there. History, 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 history. Um, so it's not for everyone. Um, but I don't think it has to be as scary as maybe some individuals think. And I spend a lot of time counseling people. Once I know your history and I understand the symptoms that you're having, we can tailor something to you particularly because it really is not one size fits all. And I do stress that during office visits. I'm like, what I do in room 1 versus what I do in room 3 is going to be completely different because you are two completely different human beings with different needs. That being said, I think that as we transition into, perimenopause to menopause, if a girl needs some help with a little bit of hormone, I am more than happy to help you out. Meaning, it's going to be what you want it to be.
yeah.
If you want to go the non-hormone route, okay, here are your options. And if you're interested and you want to try hormones, I am here for you.
Okay. That's good. Is there a benchmark that people can do? Like right now, I'm 48 years old. Is there a benchmark that I can say, this is my regular hormone level? And then once I start waking up sweating, or I'm like, I am
Right. Great
perimenopausal,
question.
can
Yep.
you test? Is there an objective way besides for my subjective craziness
Yeah.
that I might be
No, you're
experiencing?
not crazy. So subjectively, yes, if you are starting to have pain with intercourse, and I think people don't realize that they're having pain, so then I start asking real nitty-gritty questions like, okay, do you have to use lubricant to have intercourse? Do you still have the same desire that you have? Do you find that, I don't know, you'd rather be watching, I don't know, some program on TV rather than do
What
you
show is it
find that
though?
app?
I mean,
I know, right? Because if it's like Bridgerton, I might choose Bridgerton. But anyway, no.
that's a good
But
one. I
oh
think I'm blushing.
my God, I couldn't stop it. Anyway, but if you're having like itching and discomfort after intercourse, you have like this intense itching, you have diminished estrogen. I think people don't realize if you have night sweats, which can start around 35, I don't know that everybody knows that they can start so early, or they don't recognize what it like. Why do I wake up at night and I have to change my whole outfit? You are perimenopausal. You should check the box. And then, if it really bothers you, yes, we can help you. Whether you want to take hormones, which is basically you're suffering from a lack of estrogen, and estrogen will take that away. But
Mhm.
if you've decided either because you are just not comfortable taking hormones or you can't take hormones, there are still other options for you that you can go over with your healthcare provider. I
Mhm.
feel very passionate about this subject, maybe because I too am 48. And, I just feel like my soapbox can't be big enough.
Well, you know what? I mean, whatever you're putting out there, it's completely relevant to all the ladies that are our age, plus or minus 10 years. And
Right.
it needs to be said. Like, who wants to say, oh, I have vaginal dryness? I mean, who
So
wants
I
to
ask
say
at the
that?
visit, I'm like, listen, here's the
Yeah.
nitty-gritty questions I have. Are you having, intercourse? Are you happy with your intimate life?
Yeah.
Are you able to achieve orgasm? And like you have to really sort of like tease it out of people. But once you start showing, hey, I actually want to hear what you have to say, I think people are like a flower. It's like, bloop, they just open up and start telling you.
That's true. But so in the longevity of the female reproductive system, is there a time frame where, I mean, I guess menopause is really kind of the shutting down of like, hey, let's go and play mahjong and hang out and do a lot more stuff.
I have you been on my phone? I play mahjong, but anyway,
Really? I want to learn how. You'll have to send me that link or whatever, or make me a mahjong friend or whatever. But I think like the human body really says, okay, well, you are dry, you are this, you are that, because we're closing up shop and just go find other
right.
hobbies. Is that
Mm,
is that true or am I making that up?
okay, so I think it's true what you're saying is that you may have decreased desire and you may not be as comfortable as you were having intercourse. And then you have to make a decision like, is this what I want for my life? Or I'm not ready yet.
That's true.
You know what I mean? And again, it's going to be different for every individual. I think more and more ladies are like, I'm not ready yet. Well, hold on. What is going on here? And this is not okay. How can let's fix this.
Right. Okay.
And
And
I
then,
say, good for you.
yep.
We're
Yep.
living longer. I mean, right? We're all going to be here a lot longer. So
That's true.
it,
Let's keep the
I
machine
say,
working.
like, be comfortable and have fun.
Yeah. It is interesting. It's quite a predicament when one person in the relationship does decide eventually, like, okay, I'm all done. I'm just gonna, start cooking and have my hobbies. And then the
Yeah.
husband gets hold of that little blue pill and he's like, I'm still in business. And
Right, right.
oh geez.
And I have to say, like, as I hope that ladies, it's sort of like taking control of your life, right? And taking control, just living your best and fullest life. I'm not saying you have to take hormones, that's a personal decision, but always strive to live your best life. Like, you're gonna be here, you might as well have a good time and enjoy your time here.
Yep. Yeah. And for some people, sex is part of that. And some people, sex is not part of that. So they have their freedom to choose for sure.
Right.
Definitely. I like this conversation.
Yeah,
What
I kind
else
of
do
like, I
I
like it too.
have? Talk to me about the vaccine. I just
Okay,
got my
yes.
first shot the other day.
Oh,
I'm so happy.
good for you. Congrats.
Thank you.
Um, I think it's a great product, whichever one you're getting. In pregnancy, we are strongly advocating our ladies to get the vaccine. There's a study that just came out, I think it was like March 5th or something. There was a study that came out proving, yes, the antibodies are passing across the placenta to the baby.
Oh,
Um,
okay. That's good. And it's
yeah.
not harmful, the level of antibodies or the level of vaccine, the amount or whatever.
So this is an mRNA vaccine. It does not have any live virus in it. It is helping your body to recognize one of the surface proteins on the COVID um, 19 virus so that your body can mount an immune response. In, if you were to become infected, then you could either have a lesser course, okay, or hopefully, you know,
Avoid
the
it
way these
altogether.
vaccines are
Yeah.
so good, avoid it altogether.
Hmm.
And as an added benefit, if you are, so the study was done on a lady who at 32 or 28 weeks, I think she got her first dose, and then she got her second dose 3 weeks later, and then she delivered full term at 38 weeks. And still, because she's a healthcare worker, she had been tested throughout the pregnancy and had also antibody testing, so they were sure that she actually had not had an exposure. And then tested her after delivery and tested the baby and showed yes, levels of antibody in her blood and in the baby's blood, showing that she conferred antibodies to the baby. I can't say immunity because I don't know what the level would have to be,
Hmm.
but the original studies, none of them included pregnant ladies. So I can't say, you know, for sure, but so far we haven't really seen any adverse reactions. The studies are coming out literally like every day, every week they're coming out, so we have to wait. But just by the nature of how the vaccine is made, I can't see any detriment to ladies.
Mhm.
ACOG, World Health Initiative, World Health Organization, excuse me, and the CDC all advocate for giving the vaccine, not only in pregnant ladies, but in breastfeeding moms or in people who are thinking of getting pregnant. So I think I've covered
The spectrum.
basically, if offered, we, meaning ACOG, CDC,
Uh-huh.
World Health Organization, recommend getting the
If you can
vaccine.
get it, get it. And it doesn't matter
Get
which
it, get
one,
it.
Pfizer, Moderna, J&J.
Right.
AstraZeneca's a little questionable right now, but I think it's okay. We'll see.
We'll
They just
see.
have a data issue. But
Yeah.
so as far as breastfeeding moms that get the
hmm
vaccine, has it been tested that the baby takes on also some of the antibodies? Because I know breast milk
Probably.
contains a lot of, beneficial things
Right, right.
related
And
to
so
that.
she
So,
would probably um, confer immunity to the baby um, through breast milk. I can't say for sure because those studies haven't come out, but
mhm,
probably she would.
that's good. And
Yeah, it's very good.
yeah, if the mother and child pre-vaccine have been born, like the baby's been born, was there or was there not like risk to the baby if the baby catches COVID? But then other people were saying, no, babies can't catch COVID. And I was like, I don't I don't know if that even makes sense,
Right,
but
right, right.
because
So,
we went to a place and a woman who has a baby like 6 weeks old. I mean, it was so tiny, and she was
oh,
sitting there with her car seat up on the kitchen table, and my husband and I were walking through the house. It was an estate sale, so we were like one of many people
wow,
walking through the house, and I was like, and the baby wasn't wearing any mask or protection. I'm like, I don't know if that's good. And she's like, oh, babies
right.
can't get COVID. I'm like, I don't know if I'd risk that.
I I see. I hear you loud and clear. So, um, of all the ladies, I actually have it like pulled up. So if you see me looking over, there there were of all the pregnant patients, there was one lady who was delivered and her baby did have COVID upon delivery. But for the most part, let me just recap. The question is, can like mom who did not have COVID when she was pregnant, then she delivers and gets COVID, then transmit it to her baby? Is that the question?
Yes and no. Just talking about the baby catching COVID once it's been delivered, whether from a passerby or
I mean, I
whether
would imagine,
from a
but
family member that may have COVID anyway. Like,
I mean, there have been reports in children. I don't know about babies, but I mean, I would imagine possibly,
yeah.
you know.
You said that there was one baby that did have COVID. What does that look like in a baby? What does COVID look like?
I think that baby was fine. It just that they were testing because the mom was delivered due to COVID and the baby did have COVID as well. But I mean, of all, that is like one case
Hmm.
in many of ladies who the baby did not get COVID
Okay.
from the mom
So
while she was pregnant.
when people do deliver, how do you advise them to take proper precaution with their newborn? Usually it's always like, don't let too many people handle the baby. The baby hasn't had
Yeah,
shots yet and all that
right,
stuff. But
right. Same. We
COVID
have to put the
vaccine isn't,
bubble.
it's not on the
Yeah,
board for infants. So how do you tell them to treat their infant when
right. So
protecting
to me, it's the same as, like you said, in flu season. In flu season, or any season, typically in the early stages of the baby's life, we're hand washing. Now we're wearing masks. We're trying to protect the baby by making sure that the people around the baby don't have it, right? So either the people in the house will wear masks, wash hands, maybe no new people in the house, right?
them?
Because you don't know their status. And that's the best that we can do to protect these precious little babies.
Yeah.
Yeah.
And everyone try and get the vaccine for sure. Um, let me see what other types of, oh yeah, let's talk about your doing laparoscopic, one of your enjoyable attributes of OBGYN. What can be done laparoscopically? Have you ever done surgery inside the womb?
No, I am not a maternal fetal medicine specialist. So I am a general OBGYN, so my skills wouldn't extend to that. But you know, hysterectomies, either laparoscopic assisted or not,
Mhm.
um, cysts, uh, taking out
Yeah.
different aspects of the female organs through the laparoscope.
Oh, that you can get to through. Oh,
Yep, through like a little incision the
yep.
size of the tip of your finger. So typically we'll put one of those port sites in your belly button, one above each hip. And there's, lots of different things you can get through those little holes. And what's nice about it, and the reason why we push hard for it, minimally invasive surgery, is because the recovery for the patient is so much better.
Hmm.
If you have an incision on your belly, you could be down for like 4 to 6 weeks. But if you have just these little incisions on your belly, I mean, you're back in business a couple days later. Not
Hmm.
to mention the requirements for pain medicine are way different, and you're going home that day for the most part. I mean,
Yeah.
people don't really stay, whether I'm doing a hysterectomy or I'm taking out your tube or I'm taking out your ovary or I'm, taking
Yeah.
out some endometriosis, whatever. It's, for the most part, people go home 2, 3 hours after surgery, which I think is nice for everybody.
Yeah. Absolutely.
And
Absolutely.
we've decreased narcotic need, which is important these days.
Yes. I
Yeah.
remember when I had a root canal, and it was probably 10 years ago, and I walked away with an oxy prescription, and I was like, for what?
Right. Right.
And I didn't fill it. I didn't do
Yeah.
anything with it. But then like years later, I'm like, I'm so thankful that I didn't take that pain medicine that the
Right.
doctor was
Right.
recommending. I was like, "Hmm,
Yeah. So now we have something called enhanced recovery. Um, like we're treating people before they even go to sleep. So before you even go to sleep, I'm giving you pain medicine, right? I'm going to give you 2 extra strength Tylenol because um, I'm giving you some pain medicine. We're
mhm,
going to give you some gabapentin to help block some of those nerve receptors. And then we're going to give you 8 ounces of an electrolyte drink with sugar in it so that remember we used to be like, oh, you can't eat or drink anything for 8 hours. And,
mhm,
8 hours, I don't know about you, but I'm not feeling so great if I haven't eaten for 8 hours. And now I wake up from surgery and my body's really needing sugar and energy to sort of like fix what happened.
mhm."
And if I give you a little bit of sugar and some electrolytes, when you wake up, you feel like, a little bit better. So if you treat before the person goes to sleep, and then I locally treat wherever I've pretty much touched, and then now, your need for narcotic will be so much less when you wake up. And people are happy with that because if I give you a narcotic, I can increase your constipation. Constipation causes sometimes more pain than the actual surgery.
Mhm.
You're more lucid, you're more awake, you're ready to like move and walk around. You're not so sleepy that you're laying down. So lots of benefits to
I love that pre-treatment
it.
cocktail. It kind of sounds like a hangover cure as well. Like even before you start drinking or before you
Oh
go to
my
bed.
God. I didn't think of it that way, but point taken.
But yeah, I mean, everything that you just mentioned hits all the marks for
Yeah,
waking up from a surgery
yeah,
like that in a better state of
right. You're
mind
in a
in your
better
body.
state and
And
you're
yeah,
happier.
yeah, that's
So,
great. I'm glad that you guys have done that. There's a show that I want to recommend to you. It's currently on HBO Max, and
uh-huh.
it's called The Nick. And
Oh, okay.
Anick. I think Clive Owen is the main character, and it takes place in 1895, 1890,
Oh,
and it goes like now they just entered season 2. It's 1901, and
okay.
he does surgery all the time, and it's so
Oh,
fascinating. I love watching surgery and just hearing and learning and talking about what's going on. But at that point, they didn't necessarily even know that there were different blood types. So they were figuring all this out at that time. They also didn't know where they were cutting to get to what organ. Like, so they would make
Wow.
a slice in the body and then fish around for if that's where they needed
Oh,
to be.
oof.
It's a little bit graphic, but it is super interesting. And
And are these people asleep or awake?
well, the asleep part comes with cocaine. That's what they used to
Wow.
inject, and that's what they used to use as an anesthesia and an anesthetic. It was pain treatment,
Mm-hmm.
and the full-on anesthesia was cocaine.
Wow.
And it's so weird. And then he went off to he developed a drug habit where the doctor himself was abusing cocaine. Um,
Oh.
and the doctor, when he was away getting treatment, the doctor that was treating him said that we're going for the next month, we're going to we're going to replace something which is much healthier for you than the cocaine that was using. It's put out by a very well-known company called Bayer, Bayer, Bayer aspirin.
Mm-hmm. Yeah.
And they set the bottle down on the nightside table, and it was heroin. And it's like, wow,
Okay.
what
All
did
right, you got me. I might have to
people
watch a couple episodes.
Yeah, but you know what? I mean, there were true medicinal purposes for this, and Coca-Cola soda used to be made
Yeah,
with
that I
cocaine,
do.
a little bit of
Yeah,
cocaine, and I guess it makes you feel good. I've never
right.
done cocaine, nor will I ever do
Myself
cocaine.
neither.
Yeah, and it's never been
Wow.
in the powdered form. They never showed anyone sniffing it. Like back then,
Right,
it was
right.
just all liquid and,
Wow.
intravenous or,
Mm,
hypodermic. Very
interesting, right?
good show. I will text that
Wow.
to you.
I'm
You'll
sure
like
the
that.
person who got cocaine felt no pain.
Yes. Yeah, exactly. If they only knew about your pre-treatment remedy.
I
and
know, right? They were
post-
like, Tylenol, what's that?
You should send that lady to Motrin like every
I
Christmas.
know. I know. You're right. If I could get her address, though, maybe just for you.
My gosh, with 6 kids, she probably doesn't even know her name by now.
Oh my gosh. Mm.
Um, so I think I've covered all of the things that I wanted to cover. I wrote down some stuff. You and we have 2 kids, one of each. One of ours both go to Penn State, and I love
Yep.
that. And I'm definitely going to make them meet each
He's a
other.
sophomore too, right?
Yeah.
Oh, okay.
Yep. Yep. But now they'll be living
Yep.
in the same apartment complex. So I'm
Yeah,
definitely
so
going to
we'll
make
bump
them
into
meet
each
each
other.
other. Not bump in. I'm going to be like, you go find her.
Oh, yeah,
Introduce
absolutely.
yourself. Uh, are there any other topics that you might want to bring up that might help inform any pregnant people? Or, oh, you know what? We didn't talk about just regular when to start seeing a gynecologist. My daughter's
Um,
17. She actually had a cyst on her ovaries, and she continues to have that issue every few months or so. It'll be extremely painful. So she herself started going to a gynecologist just for conversation and to start
right,
opening a file.
exactly.
Um,
Exactly. And that's typically what we do. I would say, anywhere from 16 to 21, we start we're happy to have conversations with young ladies and just start that rapport. I feel so sorry for them because the first thing I say, I'm like, I'm not gonna necessarily touch you, okay? I'm just gonna talk to you. They have like saucers for eyes, and you just are like, oh my gosh. I, I mean,
uh,
the cutest little thing. I'm just like, like we're just gonna chat. So yeah, a lot of just information, or sometimes, not sometimes, a lot of times I see the patient with her mom, and we're just talking, just trying to make sure that, you know, they understand their bodies and when to check in and, what's normal, what's not normal, things that I mean, they are getting it in health class, but sometimes they just want a little bit more, and very happy to provide that service.
mhm.
Um,
Yeah, no,
and
even knowing their bodies, like you just said, knowing what each part does. I don't know if we have
right,
that level of
right, right.
conversation, but
Just, and depending on where she is in her personal life, the conversation can veer either way, but I always give the information.
mhm. That's
Um,
good.
I unfortunately have to run to a meeting,
Oh,
but
we were just gonna talk about the female orgasm. You're lucky that you're ducking out at this time.
everyone should have one. There you go.
Okay, just before you leave, back in the day for psychosis, they used to treat women with orgasms.
Oh, well,
There
I can
was
see
like
how.
it releases oxytocin or whatever,
Mhm.
and apparently that used to be the treatment where they would have the woman or have make the doctor would have the woman have an
Wouldn't work
orgasm.
today, but okay.
Yeah,
Um,
I don't know if that
I
would
don't know how
stop
that
it.
happened in the office, but
Well, just for
um,
regular female health, even if, you want to go off on your own time in your
right,
own
right,
room, it
right.
is good for your body. It
It's
does release
absolutely
happy
good for your
hormones.
body. And guess what? It's your body. If you want to touch it, touch it. Like, so I
Oh,
even tell young ladies that. I'm like, we're going to be here for a long time. Okay.
right.
So let's all just, there's just a lot of
Taboo.
taboo placed on women, especially. And I feel like every day I try to peel a little bit of it back and help us be freer and happier. I'll end on that note because there's the, masturbation is normal, having orgasms is normal, um, self exploration is normal, self touch is healthy and normal. So
Touch away.
touch away.
I think we did a good job of peeling back a lot
I do
today.
too.
It was fun. Okay.
Very fun.
You head off and you and I will connect. I'll send you the link to that show and you're going to send me a link so I could start playing Mahjong with you.
Okay. All
All right.
right. Have a great day. Thank
Thank
you so
you.
much.
I'll talk to you soon. Bye bye.
Okay.